Thank you so much for the kind introduction, and thank you very much for the invitation. I'm very happy to be a part of the Nurses Conference part as well, especially on a topic that I think is very significant, and that is supportive care in GVHD. I have no relevant disclosures, and I will try to address all aspects of supportive care in GVHD, so prevention of infections, nutrition, local therapy, physical therapy, and finally psychosocial therapy. So to begin with, I would like to highlight that ancillary therapy and supportive care are central components in the long-term management of chronic GVHD after stem cell transplantation. Also they are directed at organ-specific control of symptoms or complications resulting from GVHD and its therapy. The importance of supportive care is highlighted by the fact that one of the NIH consensus documents, one of 6, is actually dedicated the whole to supportive and ancillary care. And we know that these NIH documents are the main documents in the management of GVHD. I will start with prevention of infections because the main reason most patients with GVHD die actually is unfortunately infectious complications, and this is related to the use of systemic immunosuppression, and patients who have systemic immunosuppression at 1 year after stem cell transplantation actually have lower survival, and for that reason for us physicians it is very important to try to treat patients with at least immunosuppression as possible, and also to prevent infections as much as possible as well. For that reason, these patients need long-term surveillance for CMV, prophylaxis for herpes virus, antibiotic prophylaxis, and this has to be continued 6 months after systemic treatment, for example, steroids or cyclosporine has been stopped, not like in usual patients without GVHD where we stop at 6 months after transplant. Also, these patients, especially the ones on steroids, need to be reintroduced with posaconazole, so for prevention of invasive mycosis, because patients who do get this prophylaxis have really less invasive mycosis, and we know that this is a very dangerous complication. And also they need to be vaccinated as early as possible, so not as we thought earlier, and we didn't vaccinate them until, as long as they are on the systemic immunosuppression. Today we advise that they are vaccinated as early as possible. I wanted to share a case, a patient case with you, because this is my patient and I think it really highlights the importance of supportive care. This is a patient who was 30 years old at stem cell transplantation and who had myelofibrosis. This is important because it was a patient who actually was outpatient and wasn't hospitalized before stem cell transplantation, which of course makes it more difficult no matter how much we talk to our patients. And she had pretty, I would say, normal talk with a normal course of complications with acute GVHD developing at age 60, which needed systemic steroids. But she had so many side effects of steroids, including diabetes, that we had to stop and taper off and stop steroids really quickly. We did that at day 100. And shortly after she came back to me, she was my patient with a red eye and red mouth. At that time, I was a younger physician, and I presented her to my seniors, and everybody was pretty sure it's after day 100, after cessation of immunosuppression, it has to be chronic GVHD. Unfortunately, at that time, we had already a multidisciplinary GVHD team established, so a team of many different organ specialists, as we know that chronic GVHD is a multisystemic disorder which can affect literally any organ. And she was first seen by an ophthalmologist, a neural medicine specialist, because these were her main problems, and they were totally agreed on one thing, and that is that this was not GVHD, but actually something completely opposite, an infection with herpes virus, which was of course something that we treat completely the opposite, with decreasing immunosuppression, unlike GVHD where we would reintroduce immunosuppression. When I say that senior physicians made a mistake, it's not their fault because actually this is how GVHD of the eye and herpes simplex look like infections. So it's a red eye, and to a transplant physician, it is not clear without a special tool like it is to an ophthalmologist what is actually inside. And how important is to then have an ophthalmologist in the team can help you understand if you see the photo of, and this is taken with my patient's permission, of how the course was really dramatic of the infection, even though we were treating her in the right way. And can you imagine what would have happened if we didn't? So my first point here is that multidisciplinary approach is essential. Multidisciplinary team for GVHD is essential because, first of all, at the first step, it improves diagnostics of GVHD. I will continue with nutrition in GVHD, and here we intuitively know that nutrition is important. We have guidelines on nutritional support in stem cell transplant recipients, but this is pretty much scarce. Enteral nutrition is recommended over parenteral, safe food handling over neutropenic diet as well, but I don't know how you do it, but in many institutions still parenteral nutrition, neutropenic diet take place because all the level of recommendations are not high, as well as for acute GVHD, where still many centers stop oral intake if patients have high volumes of diarrhea, even though the level of evidence is pretty low. In chronic GVHD, malnutrition reflects severity of GVHD, and therefore you have to treat GVHD to manage malnutrition. And this is also something that has to be managed by a multidisciplinary approach, including a gastroenterologist and nutritional medicine specialist. What I wanted to mention here is not only macronutrients, but micronutrients as well. I can't mention all of them, but I wanted to mention vitamin D, because vitamin D is something that we know that has some immunological properties, and it really has in GVHD. Low levels of vitamin D before transplant really consistently show an association with chronic GVHD. As you can see here, this is the curve with patients with lower levels of vitamin D before transplant. And also patients who receive vitamin D for vitamin D deficiency and have steroid refractory GVHD, in some cases we have seen significant improvements that we attribute to vitamin D as well. This has actually enabled prospective studies of supplementing vitamin D in stem cell transplantation starting before transplantation, day -3. And these studies have really shown that supplementing vitamin D decreases the incidence of chronic GVHD. What about other aspects? Well, here I wanted to mention prebiotics because it has traditionally been said to our patients that prebiotics shouldn't be used. However, in recent times, we have learned about the role of healthy intestinal microbiota in stem cell transplant recipients, the role of disrupted microbiota, which happens because of conditioning, because of GVHD, in GVHD and in stem cell transplant outcomes. And it has really become interesting to preserve the healthy microbiota, which can be done with prebiotics, probiotics, and postbiotics. And I will here focus on prebiotics because there are studies which show that giving prebiotics, for example, to patients before transplant can really help preserve healthy microbiota. This is indirectly seen by production of butyrate, which is produced by anaerobic bacteria, which are the healthy microbiota, and patients who get this actually have higher levels of production of butyrate. Also, it seems that giving prebiotics to patients can actually prevent acute graft versus host disease, and these are really early studies, but it remains to be seen how this can be used in real life, and it is also included in nutrition. And this is then my second point, and this is what I already said, that we need multidisciplinary approach to improve treatment of GVHD as well. So nutrition, nutritionists, gastroenterologists, they're all a part of the multidisciplinary team. When it comes to local therapy for GVHD, this is also very important, especially it works in organs which are most frequently affected by GVHD, so oral, skin and eye GVHD. And this is from the same document on supportive care that I've mentioned earlier and that I recommend reading. So you see that this is really comprehensive. There are lots of possibilities and therefore, again, not possible to manage these patients without different organ specialists who know these treatments best. Also, in these many of these cases, you can actually increase local therapy and prevent the increase of systemic therapy, which I said at the beginning is the goal of all our physicians. Back to my patients. A patient, she did recover from that horrible infection that I've shown to you, but unfortunately, at about 9 months after transplantation, she had gradual deterioration of her vision. And this time she was seen again by an ophthalmologist who was sure this time that this is chronic GVHD and pretty severe chronic GVHD of the eye, which is not strange because it was in the territory of previous infection. She started topical therapy, although with signs of mild GVHD at that time, she also had indication for systemic treatment. However, she didn't want to use steroids because she related steroids to her previous infection, and I couldn't say that this is not true. But local therapy, the one we had available, so autologous eye drops and cyclosporin drops, were not improving the situation, and this led to ulcerations. And I have to remind you that severe eye GVHD can even cause perforations of cornea. So this is something really, really serious. So as I said, she had oral changes as well, but her main problems were the eyes, and this is the time point where our ophthalmologist remembered that we can try something else in her, and this is something that is already used in ophthalmology. It's called amniotic membrane transplantation. So it's a fetal membrane taken at cesarean sections, and it's used in ophthalmology in severe burns, infections of the eye. It is easy to administer because it has no HLA antigen, so you can give it without immunosuppression. And he thought that it could be something new for our patient where she didn't want systemic immunosuppression. This is how it is used. It is actually thawed and sutured to the eye where it dissolves over a week or two. And this is how impressive it looks in our patient, even macroscopically. And it really improved, healed her GVHD and had a prolonged effect. This is because amniotic membrane is rich in cytokines, in fibroblasts, which promotes healing and has an immunosuppressive effect. So far, we have used it in 10 patients and pediatric as well, and we are continuing this approach, which is a completely novel approach in IGVHD. One other thing I wanted to mention is potential of local therapy in mild GVHD, and this is something that is called autologous platelet gel that promotes healing in similar way as amniotic membrane. It has been used in wounds, and in my experience, we have used it in 5 patients, and we, at least this is the thing that we have published. We have used it afterwards as well, and you can see how impressive this can work in severe ulcers of the mouth. In our patients, we saw partial to complete responses, but what is very important, we had improved oral intake and quality of life of our patients. This is then my third point, and this is that multidisciplinary approach, working together with other specialists, can help us develop novel treatments for GVHD, which is hard for us because we are not, of course, eye specialists or mouth specialists, for example. When it comes to physical therapy in GVHD, I have to remind you that physical recovery is very slow in our patients. They come back to pre-transplant levels at 1 year after transplant, but need several years to come to the level of general population. And if they have GVHD, that happens even much, much slower. Also, every chemotherapy can cause something that we call fatigue, and that's something that occurs in cancer patients, and they feel tired as long as 10 years after transplantation. transplantation and after chemotherapy, which of course makes them rest. Inactivity leads to loss of muscles, and muscles are lost due to GVHD and steroids as well. And this is then a vicious circle that leads to more inactivity and more fatigue. It is very important to tell our patients that it's not that they should not rest, but it's the contrary. They actually need physical exercise, because there are studies, and this is one of them, showing in a randomized way that patients who exercise before, during, and after transplant, in comparison to the ones who don't, have really more endurance, more strength, less fatigue, and better quality of life. But it's not only about physical exercise, it is also about physical therapy, because beside physical exercise, there's something which you all know, it's physical and occupational therapy. And although there are no controlled trials, there are some case reports and case series which say that multi-component rehabilitation helps especially patients with sclerotic chronic GVHD. There are recommendations, but optimal timing and schedule is unknown. And although early intervention traditionally is more effective, we have to be careful here, because intense physical activity can actually trigger fibrosis, induce inflammation and trigger fibrosis in these patients. But this is where a multidisciplinary approach is extremely important, because you have a physical therapy specialist, occupational therapy specialists. Patients with sclerosis sometimes have difficulties opening their mouth, speaking, eating as well. And this is in systemic sclerosis, but physiotherapeutic intervention and home exercise can really be effective in reducing those symptoms, therefore in GVHD as well. Also, occupational therapy can help, because there are some home and work adaptation measures which you can do in kitchens, bathrooms, household in general, which can really help ease their life of our patients with sclerosis and improve their quality of life. Therefore, multidisciplinary approach can improve physical functioning of GVHD patients as well. Finally, last but not the least, when it comes to psychosocial therapy, we have to keep in mind that patients with moderate and severe chronic GVHD, and these are scales according to the severity of GVHD, have lower quality of life, as GVHD has higher grade, lower physical functioning, lower mental functioning, lower social functioning. These patients are more likely to take medications, and what is very important, many of them are actually unable to go back to work. Therefore, it is important that we know that there are options for them as well. They're called behavioral interventions, and they can be provided even by online or telehealth modalities. This is something that has really risen in the era of COVID. And this is the US example of a study where these patients are handled online, where problems are identified, and then these problem-solving treatments are introduced usually by telephone. And this has really shown to improve depression and improve the stress in our patients. So there are options for them as well. Psychologists and psychiatrists is also important, and multidisciplinary approach like this can improve emotional well-being of GVHD patients as well. So in conclusion, I think I have persuaded you that optimal GVHD management means multidisciplinary management. So it's not only transplant physicians, it is many other different specialists. And I can assure you that when you have a multidisciplinary team, like I have in my institution, nurse coordinator is the key person in this optimal GVHD management, because nurse coordinator is the one who schedules all the appointments, connects all the specialists to transplant physicians, to patients, also educates patients, and is actually crucial for all these improvements and for the improvement of quality of life of GVHD patients. So with this, I thank you, and I thank my GVHD multidisciplinary team in Zagreb.